My name's Kate Hunt. Welcome to this topic on dealing with CGM arrows and alerts in pregnancy. I'm a diabetes consultant at King's College Hospital in London, and these are my disclosures. So the objectives of this topic are to understand which real-time CGM alerts to set, how to respond to glucose above target, how to respond to predicted low glucose and low glucose alerts, how to use the arrows to adjust meal doses, and how to use the arrows when glucose is within target. So real-time CGM systems have many possible glucose alerts, but setting too many alerts or setting the thresholds too tight will lead to lots of alerts. And this may result in the person either stopping using the real-time CGM altogether because it's too annoying, or ignoring all the alerts, including the more important ones, which is sometimes called alert fatigue. So the general principle is only turn on an alert if it is something that you can do something about safely and you should do something about straight away. When people first start using real-time CGM, we recommend to start with no alerts or very few alerts and only add in the alerts once you're used to the system. And generally people start with the low alerts and then add in the high alerts. So this is a list of all the real-time CGM alerts, but the ones that we use are the most useful ones, which are the high glucose alert, which alerts when the sensor glucose reaches the high glucose threshold, the predictive low glucose alert, which alerts 20 to 30 minutes before the sensor glucose is predicted to reach the low glucose threshold, and the low glucose alert, which alerts when the glucose reaches the low glucose threshold. So when we set the alerts, we need to decide what threshold to set the alert at, and usually with the high alerts, we start with the threshold during usual waking hours at 12 to 15 millimoles per litre, and usual sleeping hours at between 8 and 10 millimoles per litre. And when people first start, we recommend you start at the top end of this range and then move down to the lower end of this range as you get more used to the system. I know that these thresholds seem high for pregnancy, but it's important that you don't trigger these alarms too often, because otherwise the system will just be too annoying. The low threshold depends on the system because they're set up in slightly different ways. The Dexcom G6 has an urgent low alarm, which is set at a threshold of 3.1, and that can't be changed or turned off. There's also an urgent low soon alarm, which will alert 20 minutes before the sensor glucose is predicted to reach 3.1. and a low glucose alert, which you can set wherever you want to. And we would recommend setting that at between 3.4 and 4, depending on how aware of your hypos you are and at what point you want to be alerted. And the idea of these systems is that the predictive low glucose alarm, the urgent low soon alert, will alert you if your glucose is falling very quickly to a low level, and the low glucose alert will alert when your glucose is slightly higher. The MiniMed 640 system is set up slightly differently. You can choose whatever threshold you like, and we would usually set it at between 3.4 and 3.6, sometimes higher for people with reduced awareness of hypoglycaemia or severe hypos. And there is an alert before low, which alerts 30 minutes before the sensor glucose is predicted to reach the threshold that you've set. And there's also an alert on low, which you may wish to turn off because you should have already been responding to the predictive low glucose alert. So having set those alerts, you need to have a plan of what to do when the alerts sound. So with the high alerts, the most important thing is don't panic. Then think about why the glucose level might be above target and what you might do differently next time. So could you change the food you've eaten, the activity you've done, the timing or the dose of the insulin? And then have a plan of what to do about it and when to do it. It's important for us all to remember the action profile of rapid-acting insulin. So rapid-acting insulin starts working in about 15 to 30 minutes, peaks at about 1 to 2 hours and lasts for about 3 to 4 hours. So if you give a corrective dose of rapid-acting insulin, if your glucose is high, this will not reduce sensor glucose immediately, and your glucose will continue to rise for 30 to 60 minutes after you've given the corrective dose. It's important to leave at least 2 hours between corrective doses. If you give too many or too large corrective doses, this won't bring your glucose down any more quickly, but it will cause hypos. So what you do when your glucose is above target depends on the time of day and whether you've got short-acting insulin on board from your previous meal. So if it's before meals or overnight when you shouldn't have any short-acting insulin left from the preceding meal, if you've got up arrows, you can give a corrective dose as you would usually, and some people may wish to add on extra insulin, which we'll talk about later. If you've got stable arrows, you give a corrective dose. If you've got down arrows, generally we would say don't correct because your glucose is already falling, but check again in 1 hour. After meals, will still have insulin acting from your previous meal, and you may still have food coming in from the meal as well. So if your glucose is above target at 1 hour, think about why this has happened, what you might be able to do differently next time, thinking about the food, the activity and the insulin, but don't correct. If you want to and it's convenient, you could go for a 10 to 15 minute walk because that will bring your glucose levels down, and then check again in 1 hour, so 2 hours after you've eaten. If your sensor glucose is above target at 2 hours, if you've got arrows that are up or stable, you can then give a corrective dose. If you're using a pump, you would use your bolus calculator. If you're using injections, generally use half the dose that you would usually give for that glucose levels, or you could use an app. If you've got down arrows, your glucose is already falling, so don't correct. So the other time that we find that people's glucose levels are above target is after treating hypoglycaemia. If your glucose level is above target at 2 hours after hypoglycaemia and the arrows show that you've got a stable glucose or it's going up, then you can give a corrective dose. If your glucose level is falling, don't give any extra insulin. And finally, if you've got unexplained marked hypoglycemia, which in pregnancy we would say is over 10 millimoles per litre, this may be due to the system failure. For example, if you're a pump user due to the pump having a problem with the pump, or due to illness, and your healthcare team will go through the sick day rules or the management of unexplained high glucose in pregnancy, which are slightly different from outside of pregnancy. So what to do when the predictive low glucose alert or the low glucose alert sounds, and this is for people who have alarmed real-time CGM. So if you have a predictive low glucose alert or a low glucose alert, your blood glucose may already be lower than the sensor glucose, you may already be hypoglycemic, so it's important to check the fingerstick glucose to confirm hypoglycemia. If your fingerstick glucose is 3.5 or above, you are going to take action to avoid the hypoglycemia. If your fingerstick glucose is below 3.5, you're going to treat the hypoglycemia. And after you've either avoided or treated the hypoglycemia, you need to think about, is there something else that you need to do right now to stop a further episode of hypoglycemia? If your fingerstick glucose shows a reading below 3.5, you need to treat the hypoglycemia. So you would have 15 grams of quick-acting carbohydrate, and after 10 minutes you would check your fingerstick glucose. If it's still below 3.5, you would have another 15 grams of quick-acting carbohydrate. If it's at 3.5 or above, you've successfully treated your hypoglycemia. The important point here is not to use the sensor to monitor your recovery from hypoglycemia. And the reason for that is that the sensor lags behind your blood glucose. So your sensor glucose will still be falling even when your blood glucose is rising. So if you use sensor glucose to monitor your recovery, you're likely to overtreat your hypoglycemia. And one way of avoiding this is when you know you're hypoglycemic, just don't look at the sensor again until you know that you're out of the hypoglycemia using a fingerstick reading. So if your fingerstick glucose is 3.5 or above, but is similar to the sensor glucose, and the arrows suggest that you're at risk of hypoglycemia, you would have 10 grams of quick-acting carbohydrate. If after 10 minutes you've got downward arrows, then check your fingerstick glucose again, because this will tell you where your glucose is. If your fingerstick glucose is the same or higher than it was before, then you've successfully avoided the hypoglycemia. If it's 3.5 or above, but lower than your previous reading, then have another 10 grams of quick-acting carbohydrate. If your fingerstick glucose is below 3.5, you would then treat as hypoglycemia. Once you've treated or avoided your hypoglycemia, it's important to think about whether you need to do anything else right now. And this is particularly important in pregnancy because a lot of hypos in pregnancy are due to the tail end of the meal bolus, because you need to give such high mealtime doses to get the 1 hour glucose in target. So what you do next depends on the timing of the hypo or near hypo in relation to your last meal. So if your last meal bolus was less than 30 minutes ago, then your hypo was probably due to either the basal insulin, and the hypoglycemia avoidance or treatment with quick-acting carbohydrate should be enough. You will have the carbohydrate from the meal being absorbed. If you're between 30 to 60 minutes after your meal bolus, the hypo or near hypo is likely because of a mismatch between the amount or timing of your insulin and your meal, and the meal carbohydrate will be being absorbed, so you don't need to do anything else. If you're between 1 and 4 hours after your meal bolus, then this is where the hypo is probably due to the meal bolus, and you will still have insulin on board from that last meal, and you are at risk of having a further hypoglycemic episode. So what you do next depends on how far you are after the last meal. So if you're between 1 and 2 hours, have a 20-gram healthy carbohydrate snack. If you're between 2 and 4 hours, a 10-gram healthy carbohydrate snack. If you're more than 4 hours after a meal bolus, then your hypo is because of the basal or background insulin, and you don't need to do anything else. It's also important to think about why you had the hypo or near hypo, and is there something you could do differently next time to avoid it, either the food, the activity, or the insulin. So when you get used to using real-time CGM, you may wish to go on to using the arrows to adjust the amount of insulin you give before meals. And there are a couple of ways of doing this, but basically if you've got up arrows, you would give a bit more insulin. If you've got down arrows, you would give a bit less insulin. One way of doing this is called the ISF rule, and this will need adjusting as the amount of insulin that you need changes through pregnancy. But if the total amount of insulin you take in a day is between 25 and 60 units, if you've got oblique arrows on the Dexcom or the Freestyle Libre, or an up arrow on the MiniMed 640G saying your glucose is rising, you would add half a unit to your mealtime insulin dose. If you've got arrows showing your glucose is rising quickly, you would add 1 unit to your mealtime insulin dose. If you've got down arrows, if the arrows show your glucose is falling, you would take off half a unit. If it's falling quickly, you would take off 1 unit. The other way of doing this is the 10%, 20% rule. If you've got arrows which show your glucose is rising, you would increase the total dose by 10%. So you would calculate the amount you need for the food and for any corrective, and increase by 10%. If your arrows show your glucose is rising quickly, you would increase by 20%. If your glucose is falling, you would reduce by 10%. If it's falling quickly, reduce by 20%. So there may also be times when your glucose is in range, but it's still useful to know which direction your glucose is going in using the arrows. And probably the most useful time for this in pregnancy is after meals. Again, because of the high mealtime insulin doses, putting you more at risk of low glucose a couple of hours after meals. So if your sensor glucose is in target at an hour post-meal and you're not predicted to go low, if you've got arrows which are up or stable, think about what you've done to achieve this glucose in range, which is great, and then check again in an hour. If you've got arrows down, think about having a healthy snack, 10 to 20 grams of carbohydrate, and the amount would depend on the glucose level and the arrows. So if you've got a glucose level of 5 with arrows showing that your glucose is falling quickly, you might want to have 20 grams. If you've got a glucose level of 7.7 with arrows showing your glucose is falling slowly, you might want to have 10 grams or even nothing. At 2 hours, if you've got glucose within target and not predicted low, again, if you've got arrows up, think about why this might have happened, but don't give any extra insulin. Check again in an hour. If you've got stable arrows, you don't need to do anything. If you've got down arrows, consider having a healthy snack between 10 to 15 grams of carbohydrate. If you're more than 4 hours after your last meal or overnight, when you shouldn't have any insulin on board from the meal, if your sensor glucose is in target and not predicted low, if you've got arrows up, check again in an hour. If you've got stable arrows, you don't need to do anything. If you've got down arrows, you may wish to consider having a healthy snack of 10 grams of carbohydrate. So when you first start CGM, it's important to start with no alarms or very minimal alarms, and go on to setting the alarms when you're used to working with the system. We would suggest you set the low alarms first and then perhaps go on to the high alarms later. When you first start using real-time CGM, it's important to avoid overreacting to the high and the low glucose readings. So if you have a low or a high glucose reading or alert, don't panic and have a plan for dealing with the common issues. Make sure you allow enough time for that action to work and remember the sensor lag, and think about why this has happened and what you could do next time to avoid it, changing the food you've eaten, the activity, or the insulin time or dose. And then when you're really familiar with using the real-time CGM, you may want to go on to using the arrows to adjusting the meal boluses. I hope you've enjoyed this session on using arrows and alerts for real-time CGM in pregnancy, and that you now understand which alerts to set, how to respond to a glucose above target, how to respond to predicted low glucose or low glucose alerts, how to use the arrows to adjust the meal boluses, how to use the arrows when the glucose is in target. But remember that this is just a starting point, and you will work out how the system works best for you as you become more familiar with using it.